So ESMO 2017 was really exciting, I think, for lung cancer providers as well as patients, because we saw a lot of really exciting results that I think will change practice. Probably the two, well, maybe three biggest practice-changing results were the Pacific study, the FLORA study, and then the BRAF V600E with dabrafenib trametinib. So the Pacific study represents one of the first big improvements in the treatment of stage 3 disease that we've seen in the last 20 years, or maybe more. I mean, it was a really, after many, many attempts at trying to improve upon outcomes with various novel agents, this is the first study that actually shows an improvement. So in Pacific, lung cancer patients with inoperable stage 3 disease were treated with standard chemotherapy and radiation and then randomized to receive a year's worth of durvalumab, a PD-L1 inhibitor, or placebo. And so far we saw really good results from that study with an improvement in progression-free survival. And the overall survival results aren't ready yet, but they will hopefully confirm the very large improvement from about 16.5 months with durvalumab to the placebo had only about 5.5 months of progression-free survival, so really dramatic improvement. The FLORA study was a frontline study for EGFR mutation-positive patients. And currently there are 3 standard of care EGFR drugs that can be given when patients are newly diagnosed: gefitinib or erlotinib, and then the second generation drug, afatinib. This study compared the first generation drugs, either gefitinib or erlotinib, with the experimental arm, which was third generation osimertinib, a T790 specific inhibitor that we also know has good CNS penetration. And here the results were also quite impressive. Progression-free survival showing that there's an improvement for the osimertinib group from about 10 months with the standard of care median progression-free survival to 19 months with the experimental.
So this is giving osimertinib frontline when normally patients would have been given gefitinib or erlotinib.
That's right. And the reason why it's a good first-line treatment is because it also, in addition to inhibiting T790, it can also hit the activating mutations. So it's not that the frontline patients had T790 at the time of diagnosis, but one of the main theories about why it's an improvement is that it may prevent or delay the emergence of T790M for these guys.
Do you think this is the end of the road for erlotinib and gefitinib?
Well, I don't know if it's the end of the road. I think there may be other ways to use these drugs in combinations, but I do think that, again, this was preliminary PFS results. Well, the PFS results were mature, but the OS results were not mature yet, although the early look was heading in the right direction. So there are some who feel that this isn't a definitive the standard of care for frontline until we see survival outcomes. But in my opinion, the very significant improvement in progression-free survival in conjunction with the improvement in side effect profile and the very good CNS penetration make osimertinib a very attractive first-line option. Just this morning, they presented results for patients, lung cancer patients that have the BRAF V600E mutation, who were treated with frontline dabrafenib trametinib, so a combination of a BRAF inhibitor and a MEK inhibitor, and also very good results there with a response rate in the 60% range and median progression-free survival in the 10-month range, similar as we've seen with other gene-driven cancers when you give a specific inhibitor. I found a couple of the posters really interesting at this meeting too. In particular, there was one from the French group about hyperprogression on immune therapy. And so this is a clinical scenario that is the kind of thing where some people believe they've seen it and other people believe that it's just what happens with cancer, that sometimes cancer does accelerate and pick up the pace, and it may not be due to giving immune therapy. But they came up with a very rigorous definition of hyperprogression, where they looked at the growth rate of the cancer before the immune therapy and after immune therapy, and there had to be a significant rise in the rate, over 50% rise. And so it was a pretty stringent definition. And out of around 240 patients that received IO therapy, they actually found 40 of the 240 had this hyperprogression. So, I think one area that we really need to work on in the future is better biomarkers for immune therapy, both telling us who's likely to respond, who's likely to have hyperprogression. I was very interested in a poster that a fellow of mine put together looking at the clinical outcomes of EGFR patients who've undergone a small cell transformation. This is a very rare phenomenon, but it's something that we don't have enough information about. And so Nick Marcoux looked at a bunch of different patients, 16 patients who had had this transformation, and saw that it was about 2.5 years from the time of diagnosis until the transformation happened on average. So this is a late phenomena. And then also that patients had a very decent survival afterwards. And so, I think a take-home message is that if patients have a small cell transformation, don't throw up your hands. It's not the end of the world. On average, patients may have a 9 to 12 month survival even afterwards.